I'm just, hi, Dr. Moyers. Okay. I just left a note. This is just so you know, Dr. Moyers, I left a note in the chat for everyone to mute their device, everyone but you. Sometimes we will pick up little crackles, but just so you know, people are invited to enter in any questions or comments into the chat, and I'll facilitate those for you. And welcome. It's so nice to see you.
Thank you. I'm excited to be here.
Terrific. Oh, I'm just thrilled to meet you and very excited to have this conversation. I am going to get us started with proper introductions in a moment, but this episode is actually brought to everyone in partnership with Become Clothing, and I'm just going to quickly talk about that for a moment. Are hot flashes and night sweats keeping you up at night or affecting your confidence by day? You are not alone. Night sweats and hot flashes are often discussed in our Perry community, and Perry sisters have reviewed Become Clothing and approved the brand for perimenopausal symptom relief. Clinically proven to help you keep cooler and drier through the night. The patented anti-flush technology in Become sleepwear, clothing, and intimates not only cools the skin, but wicks away moisture and regulates body temperature. Jennifer, a Perry big sister, says about the night dress, run, don't walk to buy this dress. I love everything about it. That material felt like magic. It's very cool to the touch, but if you sweat, it does not feel wet. I've had other moisture wicking fabrics before that don't even come close. If I could buy more things with this magic material, I would. 10 out of 10, highly recommend. Sarah says the anti-flush technology they use to make this bra definitely seems to help with moisture wicking and temperature regulation after a hot flash. Hits as well. Become also makes ultra-absorbent leak-proof panties for irregular bleeding and urinary incontinence, 2 more pesky symptoms of perimenopause. Check them out at becomeclothing.com, and don't forget your code PERRY15 for 15% off your first purchase. Thank you so much, Dr. Moyers, for bearing with me as I share all of that for the community. Dr. Carolyn Moyers is a board-certified OBGYN at Sky Women's Health in Fort Worth, Texas. With over a decade of medical experience, Dr. Moyers opened Sky Women's Health to give women direct access to their providers in a calming and unhurried environment. Dr. Moyers obtained her pre-doctoral fellowship in neuromusculoskeletal medicine, also known as osteopathic manipulative treatment. As an osteopath, Dr. Moyers brings a unique perspective to patient care. Welcome again, Dr. Moyers, to the Perry community. Thank you so much for spending this hour with us. We're here to discuss, among a couple of other things, but primarily testosterone. Not too often discussed, and therefore incredibly confusing, I think. I wonder also about the fact that social media plays such an important part, for good and for bad, on all things. And you shared a post about testosterone, which caught our eye, but there's always a lot of chatter on the airwaves, across the airwaves, as it were, and we really needed science to weigh in here. So if you would begin by telling us about this very important hormone, what does it do for us?
Yes, so thank you for having me. It's an honor to be here. I'm very excited to shed some light on this topic because it was really foreign to me as well, even as an OB-GYN practicing for a dozen plus years. And really until coming into the Menopause Society world and the International Society for the Study of Women's Sexual Health, have my eyes been open to the different areas of hormone therapy. I mean, starting out in practice, I never considered replacing testosterone. So in general, we think of testosterone as a male hormone, but it is indeed, we indeed have testosterone circulating in our body. It's made by the ovary and the adrenal glands, and with a large majority of our testosterone actually coming from peripheral conversion. So it is a female hormone as well. We just have different levels than men. And it's the one that we all focus on in men. So where we know that replacement of testosterone, where the evidence shows us that the replacement of testosterone is beneficial in those postmenopausal women with low sexual desire, what we call hypoactive sexual desire disorder. And so you say, well, oh, what is that? Right?
Yeah.
Because women across the lifespan tell me I would be perfectly happy if I didn't have sex anymore, or have a decreased desire. And a lot of that is life changes. We're no longer in our 20s and footloose and fancy free, whether we have kids or aging parents or jobs or, ailing spouse. Like there's just all kinds of different dynamics to that are going on that add stress. And so as we know, sex is a biopsychosocial component. There's a biopsychosocial component to sexual desire, etc. So hypoactive sexual desire is actually defined as a persistent or recurrent deficit or total absence of sexual fantasies or desire or response to sexual activity with marked distress or interpersonal difficulties. So if you have a total lack of sexual desire and it is not impacting you, don't care, not partnered, not bothering your relationship, whatever, it's not a problem. But if it is distressing to you, then certainly it needs to be addressed. But again, we have to look at what medications, what's going on in your with your biology, with your psychology, in your interpersonal relationships, that sociocultural aspects. So we have to kind of peel back the layers of this onion to see what is indeed going on, what are modifying factors that could be impacted to help improve sexual desire. But for women who are in that postmenopausal period, who have persistent low sexual desire, we have evidence to support the use of testosterone therapy. And when we do testosterone therapy, we are not trying to get a really high level. We want a therapeutic level to be consistent with premenopausal testosterone levels. Now, that gets a little bit tricky, right? Because we don't have great assays, reliable assays for testosterone levels. And are we, getting your total testosterone or your free testosterone level? Are we getting a sex hormone binding globulin along with that? So there's a little panel that I like to do to look at your total testosterone and your sex hormone binding globulin to kind of see how much free testosterone we have available in the body. But we like to get those labs to start out therapy. And typically with the therapy we do not have a FDA approved female version of testosterone in the US, but we use the FDA approved male version, which is a 0.1% testosterone. And typically it comes in a 5 milligram testosterone, it's a tube of testosterone, and you use just half of a mil, apply it to the back of the thigh daily, let it dry, put on your clothes, and go about your day. Okay.
Dr. Moyers, can I stop you just for a minute? Because you're giving us an unbelievably amount of useful information, but I just want to parse a few things out as I'm listening to you. Okay. And I think one of the best ways to do this is probably get right to the questions that have come into the community, because I think that will it'll just sort of answer a lot for everybody. But just before we get to that, the one thing you said, it's used for postmenopausal women. Is that only or also? So I understand we're trying to get to a pre-peri sort of phase how did you put it? Sort of levels. But is it for postmenopausal women only? Can perimenopausal women be given testosterone therapy?
Yes. The data, however, supports the use in postmenopausal women. showing an improvement in frequency and satisfaction of sexual events, as well as arousal, orgasm frequency, pleasure, responsive, self-image. The data, now keep in mind that you and I both know that we struggle having adequate research around women and sexual health in the US or nationwide, truly. So that is certainly a challenge. The studies in premenopausal women are smaller and inconsistent. So can it be used in women in the premenopausal period who have a low sexual desire and who have a low testosterone level? Certainly. Would it be, testosterone therapy in women is considered off-label anyways, right? I mean, so yes, it could be used in the right circumstance. So that's certainly something to discuss with your doctor. And I would recommend that you have a Menopause Society certified provider to help you kind of walk through those options and your health risk to kind of assess. But for the most part, the use of testosterone is very safe. We haven't really seen any adverse effects when given properly. So let me just back that up and say, we're not giving oral testosterone to women. There's an adverse effect on the lipid profile. So we want to give it transdermally. You can do like a 300 microgram patch, but typically we're using a tube of testosterone, that it's a 50 milligram testosterone per 5 grams of 1% testosterone gel that you apply a small amount to the back of your thigh or to your buttocks.
So you apply a small amount from that tube. You're not applying the entire tube
half of a
at
mil.
a time.
Okay.
Okay. Okay.
So this is going to last you 10 days. So you'll need about 3 tubes per month. So whenever I picked up a box from CVS, I literally went as a provider. I was like, I am getting calls every other day about testosterone therapy. Show me what's available. What do you have in stock for testosterone therapy? Because it's so confusing. If a patient gets a packet and they've got to use a fraction of it, and then they're having to put it in a Ziploc baggie and trying to keep it from, spilling everywhere. Like it's so frustrating. So I went to check out all of theirs. So this is what I typically do, and they wouldn't give me a fraction of like what women need. So I had to buy the whole box. It's going to last a year.
Yeah. Okay. So yes, testosterone therapy may be used. Perimenopausal women may use testosterone therapy. Obviously, this is all sort of vetted out with your gynecologist, your healthcare provider. It is given transdermally, so through the skin only, patch or with this gel that you showed us. And the data is not quite there yet to show that testosterone therapy is indicated for perimenopausal women with low sexual desire. Now that just brings me to this other question. And then
wait, I'm sorry, repeat that one more time.
The data is not there because the research just isn't there, sort of by and large, to support women's health, women's sexual health, and so on. But the data is not as full to support the use of testosterone therapy in perimenopausal women. It's richer for postmenopausal women.
Correct.
Okay. Now, sorry, just one more thing. Is it indicated specifically for those women with low sexual desire only? Is that why it's given? Is that why women are coming and asking for it? And the reason I ask that is because I have a whole host of questions that actually have to do with other sort of testosterone addressing other symptoms than low
fatigue, weight,
yes,
muscle mass. Yes. So the data is not there to support it.
Okay. So is it anecdotally helpful then when women say, let me tell you this, I spoke to someone not too long ago who said that testosterone has been helpful to her, and she was emphatic that she felt more alert, engaged, and desirous. So is that just sort of anecdotal data?
Yeah, it truly is, because whenever, and also keep in mind that this biopsychosocial component is really hard to untether, right? When we're talking about things like desire and and fatigue, all of this could be, is it a thyroid disorder, right? So we have to really peel out what is going on with your overall health, with your lifestyle, right? I've had patients who come in who feel like they're a mess, decided after starting hormone therapy that they're going to quit their job, like negotiated a year severance package to move on because they realized that the stress in their life was not serving them any longer in this perimenopausal phase, and they thought that they were going to just fall apart. So yes, we have to look at all of those components. Yes, you're always going to have the anecdotal information about, testosterone, helps me maintain my muscle mass and help with my energy and all of this. But when we look at the data overall, we're not seeing consistent data to support that it absolutely does.
Okay.
Now, does that not mean that across the nation, there's testosterone or therapy, hormone therapy clinics on corners everywhere where you can get pellets and injections, etc. Does that necessarily mean that it's working or it's doing what it says? No, it doesn't. And we worry about these super therapeutic levels of of testosterone in women that they're getting with pellets. And so that's why the Menopause Society does not support the use of pellets. There's inconsistency in dosing. I don't know what byproducts are in them. And, I can't take it back. Mm-hmm. And so I have a real problem with that. So for the most part, we are sticking with transdermal estrogen. The data supports it in the use of low sexual desire in postmenopausal women. I would love to say that it fixes all of the other things, that sure. I am a beast in the gym and I have got this lean body mass,
Right.
And I have all of the energy. But the truth is, we have to consider when we think about hormone therapy in general. Yes, sometimes we started in perimenopause, right? Especially when periods go off the rails and we need to manage those cycles. Hormone therapy is incredibly helpful. And we talk about hormone therapy, we're talking typically about estrogen and progesterone. That's what most women know about. And the estrogen definitely helps with those vasomotor symptoms, hot flushes and night sweats, helps with vaginal dryness. The progesterone protects the uterus if you still have one, helps with sleep. So those are very beneficial. If you have done those things and we're still having a low sexual desire, do we have vaginal atrophy or genitourinary syndrome of menopause? Are we having, is there pain with penetration? We have to address those matters. Maybe we need local estrogen therapy. And if we've cured that and we still have a low desire, do we need to add testosterone therapy, or is Addie a better option for you? Because we definitely have options for low sexual desire. Addie, interesting enough, is indicated for premenopausal women because that's where it's been studied.
Addie is, what is that?
Addie, you do not know. Okay.
I
Addie.
Don't. I know you are schooling us some more.
Let me introduce you to Addie. Addie is indicated for HSDD. It's the little pink peel, and it is fantastic. It's really safe for women. They take it at bedtime. It helps with sleep and the number of sexual fantasies, wanting to have sex again, renewed interest in partner's initiation is really there. It is given.
This is wild. I can't believe we've never heard this. Okay. Go on. I'm sorry. I'm like, wow. The doors just blew open. It's a pill that you take at night. Mm-hmm. It's a hormone?
No, it's non-hormonal. It acts on the central nervous system. Yeah.
Okay.
So yeah, it releases dopamine. So very, very effective. So I typically, when we're talking about treating sexual desire with medication, I am going to do like a 12-week trial. So I'll do that with testosterone and also with Addie. And there's also another medication called Vyleesi that's an injectable for sexual desire. That's for another topic because everybody came here to hear
let's
another day. But there are definitely options for women now for low sexual desire, which is really exciting.
Okay. So Dr.
Yeah,
Moyers, thank you for that. I want to get into the questions that have come in from the
of
community.
course.
There's one right here I'm going to start with.
Mhm.
Do you have a target testosterone range on lab tests for your patients?
Yes. So we do want to monitor your testosterone levels. So first of all, we would get a testosterone and sex hormone binding globulin prior to starting you on therapy, because if you have an elevated testosterone level, or you're the high end of normal testosterone level, then you're unlikely to benefit from testosterone therapy. Okay. Or if you have a significantly elevated sex hormone binding globulin. So we do want to monitor that. So we don't use a testosterone level to diagnose HSDD, hypoactive sexual desire disorder, but it is useful in the treatment and therapy, because we want to maintain you at a therapeutic level. Now, I will say that gets a little bit tricky because every lab has a different variation of normal, right? And it's based on their test, which may be, is it truly set for women, right? Because we want it to
Yeah,
be in that premenopausal normal range for women. And so
sure.
it's going to depend on your lab, but it's
Okay.
not in the hundreds.
Okay. Okay. I want to
It's
put a
closer
pin
to
in that.
30.
Yeah. I want to put a pin in the level amount for a moment.
Mhm.
Because that's really important. And you started to talk about that. I definitely want to return. I just want to read to you a question that came in to the community. So I've started a small amount of testosterone. It's a rapid dissolve oral compounded pill, goes in her mouth. She's been on it for about 45 days. She recently read that they could cause clots. She admits it's a Google search and she's just not sure if it's true. She does have an appointment pending with her gynecologist, but could you speak to any of that?
Yes. So testosterone therapy should not be taken orally. The international and nationwide studies or societies do not support this in any way. The research does not support it. Adverse lipid effects, cardiometabolic issues could occur. So transdermal is the way to go. I don't know of any indication why you should be on a compounded testosterone, because we have in all countries, we have at least a FDA or whatever your regulatory board is, we have approved male versions that we can use safely, knowing that there is consistent dosing so that I know what you're actually getting every time. My problem with compounding is that there's more inconsistency in dosing. What are the byproducts? What are the preservatives, et cetera? And so, yes, that is concerning to me because for the most part, it's relatively safe to use transdermal testosterone with little. I mean, so what are some side effects of taking testosterone? Right, that's important for us to discuss. So with the transdermal physiologic dosing, so that, we're just trying to keep you in that normal female range. Typically you might have some acne, you might have a little hair in places that you don't necessarily wanted. And honestly, that it's when we're putting you in a therapeutic range, that's not the common. I've had one patient in the last 3 years who has discontinued it for that indication. But that are the more common side effects. The things that we worry about are like clitoromegaly, so the clitoris significantly enlarging, having alopecia, the bald spots that occur, voice deepening, right? So these are things that can happen when you're on the super therapeutic levels, like with the pellets.
Okay, terrific. Thank you for that. I'm so glad
Mhm.
that question was able to be answered. That's really important. And I'm glad she's going to be going to her physician. You've just answered several questions, sort of rapid fire, that did come in from the community. Will I grow hair? Will I, where I don't want it? Maybe, but it's not common. Will I get acne? Maybe, but it's not common. Will I gain weight? I don't know if you got to that one. Someone asked about that.
Yeah. So I think it depends on who you ask.
Okay, sure.
So that has not been the case in my practice, that I have really seen that. If anything, I feel like that patients who are on it for the right reason and who are on it, like, can you use testosterone therapy by itself? For instance, someone who is otherwise without symptoms or doesn't want to be on any hormone therapy, or, for vasomotor symptoms or whatever, could they just be on testosterone therapy for low sexual desire? Sure, right? But for the most part, patients are on it in combination. So if we're improving sleep, if we're reducing hot flashes, if we're reducing vaginal dryness, then there's certainly a more of an opportunity for an interest in sex, right?
Mm-hmm.
And also more energy, because if we're sleeping better, our metabolism is better, we're more motivated to get our exercise in, etc. So initially, when you start hormone therapy, you may see a rise in weight, and it's more water weight, but typically that is not a big factor. And I was listening to a discussion with the International Society of Women's Sexual Health this morning, and they did mention a slight weight gain, looking at a particular, one of the particular studies, right? And looking at research, I get it, that it's completely overwhelming, because one day this is right and one day this is wrong.
Sure.
But I will tell you, in typical practice, that has not been an issue using a therapeutic dose.
Okay, thank you for that.
Mhm.
Forgive me if you answered about voice deepening. I missed
Yeah,
that, and
that's
someone did ask about that. Is that one of the
yeah,
concerning issues, or it could have?
that is a potential side effect with the really high super therapeutic dosing. And so that's another reason why, when we're treating you for a low sexual desire on testosterone therapy, typically we're going to see maximum benefit around 8 weeks. Sometimes
Okay.
that's closer to 12 to 16 weeks. You may start seeing some benefits up at 4 weeks, but typically, again, that's 8, 12, 16 weeks, somewhere in there. So if you have gone 6 months on testosterone therapy and not seen any improvement, it's time to stop.
Okay.
Also, we're going to monitor your levels along the way. So we've tested you beforehand. We start hormone therapy. We're going to test you at 6 to 12 weeks along the way to make sure that we are in a therapeutic range and we're not up here and need to adjust the dosing.
That's so helpful, Dr. Moyers, because I'm imagining too, and I'm sure you've heard stories like this, but when we go into our physician's office, we're really at the mercy of their knowledge and time and understanding and so on. And if we go in, and someone did ask this, you've spoken about testing levels several times now. Should we be asking to have our levels tested? And here's what happens so much. I know you know this, but we may go into our gynecologist's office and say, and we're like, 45, 50, something like that. We're still getting a period, but it's changing. We're really tired. We're feeling anxiety. There are a whole host of symptoms that are happening. Our doctor says, you sound perimenopausal. Let's go with that. And would you benefit from insisting, asking, could you check my testosterone specifically, because my desire is so low? Or are you really, like, this is, I think, where we get sort of stuck in the minutia. We're swirling with so much stuff going on.
Yes, 100%, 100%.
Okay.
I hear you. I sit with you. I get it.
Yeah.
Okay, so it is incredibly confusing, right? A lot of women are juggling the kids and the job and the parents and all of the things in midlife, and it feels incredibly overwhelming. And then your periods want to act up like, I don't even need this period anymore. I'm not
Yes.
building a nest. What is going on?
Right.
So yes, I hear you. The problem is that there is no lab test that is going to tell me you're perimenopausal.
Right.
You are perimenopausal based on your collection of symptoms, ruling out other things, right?
Right.
Do we have a thyroid disorder? Do we have anxiety, or is the anxiety related to perimenopause?
Right.
We really have to peel out all of these things. It's so multifaceted. Um,
Yeah, go ahead. I'm
so,
sorry.
so again, the data tells us that using testosterone in postmenopausal women is helpful for arousal and satisfying events, etc. We don't necessarily have that data for perimenopausal women. However, if I have managed the periods, taken care of the hot flashes, managed the mood and all of this in perimenopause, and we still have this low sexual desire and we have a low testosterone level, I do replace testosterone if that's what the patient wants to do. Now, some people are like, oh, I don't want to, I don't want to risk the side effects, or, I don't want hair growth, or I don't want acne. Maybe they had horrible teen acne and that's something they never want to revisit. And so in that instance, I'll say, okay, we have some other options. We have Vyleesi, we have Addyi. Let's talk about the different options for treatment.
Interesting. Thank you so much for that. Here are some things that people have asked. Should I not use testosterone to treat this? So should I'm interested in testosterone to treat, and I will read this list of things,
Okay.
but is it not a good idea?
Okay.
Fatigue. We've talked about that a bit. Low mood, cognition, muscle weakness and poor memory, bone loss, dementia, or breast cancer. It's a long list, I know.
Yeah. So right. So it's not indicated for use in any of those.
Okay.
Whenever I'm hearing these things, it's not used in the reduction or risk reduction for breast cancer. However, its use has not been shown to increase the incidence of breast cancer. But we don't have data on long-term use. It's just not there. It's not that we have a worry that it causes breast cancer. It's just that we don't have the data. So whenever I hear those collection of symptoms, I absolutely think perimenopause and estrogen is key. And I also think, do we have a vitamin D deficiency? I mean, I literally have had a patient come in with I heard all of her woes of her business and her marriage and her sex life and da-da-da. And she thought that this was menopause. It was here. And she was vitamin D deficient, and we've replaced her vitamin D, and she is living her best life now, thinks that we are miracle
That's
workers.
amazing.
And it was all vitamin D deficiency, because guess what? Back pain, joint pain, moodiness, fatigue, all related to vitamin D deficiency. And most of us aren't getting adequate vitamin D in our diet. So it's not always testosterone. It's not always your hormones.
Yes. Thank you for that. Thank you for that. Another question that I thought was interesting: is testosterone therapy contraindicated for someone who takes antidepressants?
No.
I'm not sure where that came from.
No.
But
so no, absolutely not. So
Okay.
SSRIs and SNRIs are actually one of the non-hormonal options for treatment of vasomotor symptoms in perimenopause and menopause. So no, it's not contraindicated at all.
Okay. We talked about, and you brought this up, and I asked to put a pin in it. This sort of like I forget the terminology you used, but the overdosing essentially of testosterone in this case, maybe other hormones in other cases. Can you speak into that a bit more, and just sort of, I guess, again, for those of us who know nothing or next to nothing, or are getting our information not perhaps from a place of sound science, and we have very low sexual desire, and we're interested in sort of feeling, less fatigue, more sort of alert, connected, whatever.
Mhm, mhm.
What is too much, and what should we sort of walk into a doctor's office armed knowing, so that if someone says to us, your levels are really low and you should be on this some amount that just sounds wildly high, but we don't know what are sort of the red flags? What should we really know?
Okay, so if I want you to be empowered in the doctor's office and what to know in regards to testosterone therapy, it's one, are my testosterone levels low? Have we addressed other health concerns, issues, other hormone therapy? Because if you are hot flashing, waking up in the middle of the night, can't get back to sleep, over caffeinating during the day because you didn't sleep well, but then can't get to sleep because you over caffeinated, it's this vicious cycle. And if we're not addressing those issues first, testosterone is really not going to be the cure-all, right? So we really have to look at lifestyle, optimizing sleep. What other hormone therapy do we need to be on? So arming you with information. If you have a low testosterone level and these other things are addressed, honestly, again, Addie or flibanserin is the name of the drug, is indicated for premenopausal women with low sexual desire. So if you went based purely on the science, then Addie or Vyleesi would be a great option for perimenopausal women for low sexual desire. But if we're looking specifically at testosterone, again, your provider may say, well, it's not indicated. Or they may say, well, we can trial that given that your testosterone levels are low. We've addressed these other things. It seems reasonable that we'll do a trial. And so when doing that, I would anticipate that you would have blood work within 3 to 6 weeks of starting your testosterone level again, so that we can adjust and make sure that we're keeping you in a therapeutic range. You had asked earlier, like generally, what are those levels? Somewhere around 27 to 38 nanograms per deciliter. So again, it's got to be apples for apples. Is a nanogram for a deciliter? What are our measurements here? So generally 27 to 38, not these 150, 200, 250 that I've seen in individuals coming in with pellets. So, knowing that we're going to review your lab results every 6 to 12 weeks while you're on therapy, knowing that if you've gotten no benefit at 6 months with consistent use, then we are not going to continue therapy. It can be continued for up to a year, and then consider taking a drug holiday and seeing if you continue to need it. And the only reason is that it's been studied up until that point. We don't have long-term data on use. I'm sure, that'll come over the years, and, in a couple of years or months, we may be having a different discussion.
Yeah. No, this is so
But this is
helpful.
just based on what we know, what we have now.
Okay, thank you so much for that. That's incredibly helpful. I think, we want to at all times sort of be giving people not only the right information, but the ability to self-advocate. And so
Absolutely.
just kind of knowing, most of us don't know
Nanograms per deciliter.
Yes,
right?
that I
Right.
couldn't even read my own spelling, but yes,
Right.
we would have no idea. But sort of having that information in our back pocket when we go pursue assistance is very, very helpful. Dr. Moyers, you mentioned vitamin D sort of as an umbrella that kind of hit a lot of marks for a patient you had who seemed like everything was going off the rails. Are
Yeah.
there any other vitamins, or I don't know, any other approaches? You mentioned lifestyle and sleep and these things that we know to sort of always be kind of tending to and aware of, but is there anything that we can take that's over the counter or in our kitchens already that sort of helps keep these levels where they should be, or does that just not happen?
Okay, are we talking about vitamins in general or supplements in general?
You tell me. Just
Mm,
if that's even a thing. If someone asked about nutrition, and
yeah,
I have
yeah.
no idea.
So, okay. So when it comes to lifestyle, if you feel like your life is falling apart, but you have significant stress and you're not moving your body and you're eating processed foods and we're not getting morning sunlight, these are all things that I go, whoa, like we first have to take a hard look at ourselves, right? And we need to be moving our body. We need to be getting morning sunlight. We need to be doing some sort of debriefing or stress reduction in preparation for bed, similar to like what we do for our kids. You have the bath time routine and a story and brush the teeth and snuggles and go on down to the bed, right? Keep the room nice and dark and cool. All of these things. We stop doing that for ourselves and we hurry to bed to get some sleep. And then we wake up at 3 a.m. and we've got all the world's woes on our mind. And we're running through our shopping list and what needs to happen the next day and can't get back to sleep and we can't figure out what's going on. And a lot of it is that we're not managing our stress well. So one of the tips I love is to have women keep a notebook. I have mine with me all the time. Keep a notebook on your bedside table and you're going to do a thought dump and just drop it on down there. Everything that's bothering you or worrying you or that's on your mind or your to-do list. This is a place of no judgment. Doesn't have to be spelled correctly. Doesn't have to be PC. You just put it down, get it out of your head, leave it alone. Know it's there if you need to touch it tomorrow. And making sure that your room is between 64 68 degrees, that it's dark, that you put an eye mask on. I love to take magnesium glycinate at night.
Yeah.
Before going to bed and aiming for that. And if I cannot sleep, if you wake up at 2 or 3 a.m. to tinkle and you can't get back to sleep and you've laid there and tossed and turned and ruminated, after about 20 minutes, it's time to get up and you're going to go to a quiet space and read a book or journal or something of that nature. But what do? We get on our phones and our devices and we have this dopamine hit and we can't get back to sleep.
Right.
And
right.
we think somehow, something's wrong with us. Our brain is doing exactly what it's supposed to do.
Okay.
So really protecting and preserving our sleep is number one. And we just stop doing it for ourselves. We do it for our children. We don't do it for ourselves. So that's huge. And then when it comes to diet, I love the Galveston diet. I'm sure your population
We've spoken
is
with her.
well
Yeah.
aware of the Galveston diet. I mean, it is the only science-based diet that we have that is specifically for peri and postmenopausal women. I typically recommend for my patients at least a 12-hour window of fasting. And so that means that we stop eating a couple of hours before bed. We hopefully get our 6 to 8 hours of sleep. And then we're not eating for a few hours after getting up. And so really though, it doesn't have to be a hard, 16 hours of fasting. I do believe we need lean proteins and anti-inflammatory foods, less packaged foods, more eating at home. These are the things that we have asked food to make us feel better in our society. We're eating for comfort, we're eating for celebration, etc. And so a lot of what we're eating is making us feel ill and is not helping our waistline. Carbohydrates are no longer our friends.
Right. But in terms of like testosterone sort of directly, it's not, these things are sort of general lifestyle,
general health and lifestyle.
Okay.
If you're asking me like what you can Google, like what's naturally going to increase my testosterone levels, potentially some exercise, healthy eating, etc. But we don't have anything that's like 100%, right? Or we wouldn't have men on testosterone therapy.
Right. Dr. Moyers, someone asked here, and I want to get to her question. What are the dangers of testosterone levels in the 1 to 200 range on pellet therapy? What should people be looking for if it's just too much?
Right. So lipid profiles, carbohydrate metabolism, cardiometabolic issues. We just don't know. We just don't know the effects of these really high doses on women. And there is a concern for cardiovascular risk because of adverse lipid profiles on the supratherapeutic levels of testosterone.
Okay. So cardiovascular health is at risk on super high levels of testosterone. And the issue with pellets specifically is there's no sort of way to keep dosing consistent across manufacturers, and that you have to sort of ride the wave out because it's inserted under the skin. You can't have it removed. You need to sort of just let it be until it dissolves. Is that correct?
Some individual, now I don't put in pellets at all, but I do have colleagues who do, and some can be removed.
Okay.
Yeah, but a
Okay.
lot of my patients have said that they don't like the incisions and the scarring that occurs with the incisions.
Okay. I know this is off of the testosterone piece, but I did want to give you opportunity to speak about osteopathic manipulative medicine. And
Yeah.
the one question I had is this the same as pelvic floor physical therapy?
No.
Okay.
So great question. I love that you're bringing this up because so many individuals, we've heard of osteopathic doctors, but don't necessarily understand what makes them unique and the osteopathic skill set that we have. So osteopathic manipulative treatment or osteopathic manual medicine, manipulative medicine, is a hands-on drug-free skill set that all osteopaths have. Some use and some don't. But I did a neuromusculoskeletal medicine fellowship. So spent an extra year because I thought I'm going to be a DO and I don't know that I could use this skill set, because you learn it in your first 2 years of medical school. And so it is incredibly helpful. I work a lot with pelvic floor PT. Some of the things that I do are consistent with pelvic floor PT, but pelvic floor PTs have much more time to really tailor your therapy and work with you on your exercises and your stretches. So they're working on the strengthening and conditioning with patients. A lot of what I do is assess and diagnose and then refer them to pelvic floor physical therapy. But hands-on drug-free treatment that I use a lot for pelvic pain. I also use this in combination when someone has done pelvic floor physical therapy and still has persistent like vaginismus or hypertonic pelvic floor, and will inject Botox into the pelvic floor to allow for relaxation so that with pelvic floor physical therapy, now we can actually retrain those muscles. We kind of break that cycle, that neural pathway of pain and catastrophizing that happens. And this really kind of ties in with our testosterone talk in that we're talking about sex and pleasure. And if we have a hypertonic pelvic floor, whether that's because we're stressed and we clench our jaw and we clench our pelvic floor involuntarily, we don't even know we're doing it. And then we wonder why it's painful with insertion. It is something that I use also. So I've had patients who have failed pelvic floor physical therapy come to me and got injection with Botox, done a couple of osteopathic treatments and gone back to pelvic floor physical therapy, feeling great, but now we're just reconditioning. So it's a really helpful skill set that I use for women. Now, like joint pain is one of those things that comes along in perimenopause and menopause. Doing our hormone therapy definitely helps with that. But a lot of patients love to have this hands-on drug-free treatment to realign and feel great in their body. I use it a lot for pregnancy and postpartum mamas, but it's wonderful for women of all ages. And a lot of people have told me they liken it to chiropractor, but it's a more gentle technique. Now, there's a large variety among providers as well. You have one DO who's going to do all high velocity, snap and crack the back. And then you have others who it looks like paint drying, like they're not really doing anything, because they're doing more indirect soft tissue type techniques. So there's a large variety. And because I treat women in all kinds of stages of, feeling more fragile in their body type, I have to have a whole bag of tools to use that are appropriate for each individual.
Great. Thank you for that. Are there anything I've missed, any major thing we should know finally on testosterone, anybody who's contraindicated? We understand now our levels should be very low. We understand that it's primarily to treat low sexual desire. It's anecdotally used for energy, sort of feeling plugged back in. People use that terminology a lot. And is there anything I've missed that we should really understand about this hormone?
Yeah, I think it's important, one, that we're not exceeding the upper limit of a normal reference range, that we're monitoring, 6 to 12 weeks throughout to make sure that we're not exceeding that. That you're getting a baseline liver function test and fasting lipid profile, because if you have liver dysfunction, or if you have a significant cardiovascular risk with your cholesterol panel, this is something we're going to be addressing with your internal medicine or primary care doctor prior to considering this. Or we may consider another option for treatment for low sexual desire. Testosterone therapy may not be right for you.
Okay, great. Thank you, Dr. Moyers. What I always like to ask guests who've been here with us, sort of what's next for you, if anything. Don't feel compelled that there should be, but many people have things they might want to share about what's going on with them in their practice or so on.
Oh, that's so kind of you to ask. I'm just working on growing my practice. I'm in Texas. I'm in the Dallas-Fort Worth area. But in the immediate future, what's next is I am interviewing Abram Blooming later today for Sky Women podcast. So
Terrific.
I'm growing a podcast, growing a
Good
practice, raising, 3 little boys. One's 18, so he's kind of done, but
yes, but 3 left, 3 remaining.
3 at home left. Yeah, we're back to school this week. So yeah, thank you so much. It's been a pleasure.
Thank you so much. It has been a pleasure. Very, very eye-opening. I think that I feel like it's this little magical thing that we, might be right for many, might not be necessary for many, but I feel like we have much greater clarity thanks to your help, and a real sort of like baseline sort of expectation.
I think managing expectations is huge, but also advocating for yourself, because only 20% of medicine residents actually are comfortable having conversations about menopause.
Right.
So if you're feeling dismissed, it is because they just don't know.
Right. Yeah.
They just don't know what they don't know.
You said earlier, excuse me, that testosterone was sort of new to you in your practice when you began. And I that just a light went off for me. I think this is much more common for physicians than we all know. I see that that's rapidly changing as, this conversation is amplified by us sort of like in the masses, demanding more attention and information. But these conversations are so helpful no matter what. So I thank you for that. I thank you to Become Clothing for partnering with us on this episode. And I just want to mention that you can use code Perry15 to receive 15% off your first purchase. Dr. Moyers, thank you so much. Thank you to everyone who joined us on the call today, and look forward to speaking with you another time.
Yeah, it's been a pleasure. Thank you.
Thank you. Thanks, everyone. Be well. Bye-bye.